of delaying, I just hand over to our President, Dr. Rajat, to say a few words.
Hello, everyone. Welcome to ASAMI India webinar series. I'm Dr. Rajat Agrawal, President ASAMI India. And every month we organize, usually on the first Friday, our webinar series. This series is the basics of Ilizarov and limb reconstruction. And this month, it's being hosted by the Karnataka chapter and our executive committee member, Dr. Aradhana Rathod, is organizing it. And we have very important topics this month: the aseptic non-union by Dr. Satish Nesari, and infected non-union by Dr. Aradhana, and the case discussions by Dr. Varush and Dr. Maruti. So I invite and request Dr. Satish Nesari to present his talk on aseptic non-union. Some words about Dr. Satish. Dr. Aradhana, please have an introduction of the speakers, and then we can have the talk. Dr. Aradhana.
Yes, sir. Yeah. Thank you so much, sir. Today's theme for talk will be non-union. So first and foremost, I thank Harshad Shah, sir. Sir is professor in Saptagiri Institute of Medical Science, and we thank him for joining us and being mentor for today. First speaker is Dr. Satish Nesari. Satish Nesari, sir, is Associate Professor in Belgaum Institute of Medical Science, and sir is very well known for his difficult Ilizarov cases. Second speaker is myself. I'm Dr. Aradhana Rathod. I am Assistant Professor in Bangalore Medical College, and I am a Ilizarov and foot and ankle surgeon. Third speaker is Dr. Maruti. He is Professor and HOD of Orthopaedics at Chamarajanagar Institute of Medical Science. Sir is much interested in Ilizarov. Our last and final speaker is Dr. Varush. Dr. Varush is a very good Ilizarov surgeon, and he is right now practicing in Gokulam Orthopaedic Center at Mysore. So, shall we start the first talk, sir?
Yes, please.
Yeah. First talk is by Dr. Satish Nesari, and his topic is aseptic non-union. Over to you, sir.
Yeah. Okay, am I audible and my slides are clear, Aradhana?
Yes, sir. Yes, sir. We can see you and also we can hear you.
Yeah. Very good evening to all the viewers and our ASAMI executive members and working committee members. And best wishes on Deepavali from Belgaum from here, from my side. So I have been given the topic of aseptic non-union. So by definition, non-union occurs when a fracture have failed to unite and more than expected time and is not likely to heal without any new intervention. According to FDA, it is also defined as established non-union as established when a minimum of 9 months has elapsed since fracture with no visible progressive signs of healing for 3 months. So, but in such cases where there is bone loss secondary to a compound fracture, so it is also a type, it's a day one non-union. So another definition is that fracture that in opinion of treating physician has no possibility of healing without further intervention. So the causes for non-union are poor vascularity, that is poor biology at the non-union site, instability, infection, and many of host factors. So as we know, soft tissue is the mother of bone. The soft tissue attachment, periosteum, intact blood supply to the bone all are required for a proper bone healing. Along with that, this functional activity of the muscles and joint, which provide axial movement at the non-union site, are required for healing of a fracture. So coming to instability, uh, interfragmentary motion diminishes callus formation. So this interfragmentary motion between the fragments will cause spasm of the vessels in the region, and because of mechanical damage to the vessels in the region, there will be diminished blood supply, hence there will be diminished callus formation. This fragment mobility also causes reflex spasm and narrowing of the vessels supplying the callus. So this will lead to subsequently lead to venous stasis and thrombogenesis at the non-union site. So there are many classifications for non-union. Uh, there are vascular and avascular, hypertrophic and atrophic. So in hypertrophic non-union, there will be a callus formation. So depending upon how much the callus has formed, it is classified into elephant foot, horse hoof, and oligotropic. In avascular non-union, there are a torsion type. So in the torsion type, there will be a butterfly fragment, and one side of the butterfly fragment unites, and the other end doesn't unite. In necrotic, the butterfly fragments go for a necrosis, and it's known as necrotic non-union. In a defect, because of bone loss, there will be so defect, and it is also known as day one non-union. In atrophic non-union, there will be intervening fibrous tissue, and the bone ends they are tapered, and they are avascular. So Paley classification is widely used. So it is mainly the classification depends upon how much the bone loss is there, and whether it is a fixed or a mobile non-union. Again, whether it is associated with a deformity or no deformity, and whether the overall bone length is maintained or no. So these are taken into consideration, and Paley has classified according considering these factors. So radiological evaluation is very important. Apart from AP and lateral views, we sometimes we may need to take a 45-degree oblique, internal oblique, external oblique views in order to properly diagnose the non-union. Sometimes we may have to get a CT scan to establish the diagnosis of non-union. Coming to hypertrophic non-union, as I said, there will be a good callus formation. Biology is very well maintained. There will be viable bones, soft tissue is viable, bone ends are vascular, but the stability is lacking. So here the main treatment will be providing stability. And along with hypertrophic non-union, if there is a deformity, we may have to correct the deformity also. And here absolute bone graft is not at all required. The hypertrophic non-union, the treatment is since the periosteum is intact, just by distracting the non-union site will lead to a formation of a new bone, and a good union can be achieved. But it is not compulsory that we have to do a distraction. Even a compression also will heal, but subsequently it can lead to a shortening. So both distraction and compression work very well in a hypertrophic non-union. So in stiff hypertrophic non-union, we can just if we just distract, it will heal the fracture. In mobile non-union, so we have to convert it into stiff non-union by giving a compression at the non-union site, which increases the stability. So for proper bone healing in compression, good stability is required. So compression, so moderate and constant compression will stimulate the reparative regenesis of the bone, whereas marked compression suppresses regeneration, and even it can cause a necrosis of the bone ends. So healing occur in compression is mainly because of improved bone fragment contact. And also along with this, we have to provide axial loading with good supply, which helps in stimulating the osteogenesis. In distraction, as I said, intact periosteum is required so that whenever we distract, the cambium layer which is present inside the periosteum has a pluripotent cells which will lay down the connective tissue and subsequently good bone formation. So, in order to have a good compression or distraction procedure, good stable frame and good stability of the bone fragments is required. So, coming to stability, we have two types: intrinsic stability and extrinsic stability. So, intrinsic stability is how we achieve stability at the non-union site. Suppose for an example, on the left side you can see the tapering ends. This is a highly unstable bone fragments. So sometimes one may need to do a squaring osteotomy or just to freshen up the ends in these manners as so you can do it in a transverse manner so that the ends they fix properly and stability can be achieved. Sometimes you can interlock the fragments in other lower two diagrams. So in such a manner, if you do it, we can achieve a good intrinsic stability. Coming to extrinsic stability, it is the stability of the frame. So again, how to achieve a stable frame is another big topic, and it is discussed in almost all of the workshops. So we can use any implants, but I am quite happy with the Ilizarov because it is axially unstable. It's a versatile apparatus. It's more modular, can correct any type of deformities. Limb length discrepancy can be addressed, and it is very well acceptable by the patient. We can start early mobilization, and also the advantage is you can span the joint. So coming to atrophic non-union, as I have already told, it's also known as avascular non-union. The ends of the bones are avascular, and soft tissue, that is fibrous tissue, is interposed. So here the biology is also poor and stability is also poor. So the treatment here is we have to uh, provide a good stability, and bone graft is required. Debridement, that is the ends has to be freshened till we get a good vascular bone, and excision of the non-vital bone. So necrotic, so we have to take out the butterfly fragment, necrosed fragment, and convert it into a gap non-union, and proceed with bone transport, or depending upon the gap you can do other procedure like bone grafting or vascular graft, or uh, uh, some other method. So in defect also we have to excise the bone ends and then do a bone transport. We have to so we have to know when to open the non-union site. Sometimes we will be confused whether to open it or no. So usually we open the non-union site when we try to remove the sequestra or to remove the implant which is present. We open the non-union site to do bone grafting and also to reshape the bone ends to get a good intrinsic stability. So next question is, we have seen the compression will give a good healing. So how much to compress? So when we compress excessively, there will be bone end necrosis. So once patients start complaining of pain, we have to stop compressing. So the role of corticotomy here is it increases the vascularity, and most often in aseptic non-union, it acts as a defunctioning osteotomy to eliminate shear forces at the non-union site. So these are the example. Here is a 19-year-old boy with post-traumatic neglected hypertrophic stiff non-union. So here he had a deformity of the varus procurvatum, deformity of the lower end of tibia. So a proper planning was done, and so hinges were applied at the apex of the deformity. This is how the graphical method of planning is done, and the either assembly is applied and gradually distracted. I just did the distraction. So at the end of the distraction, you can see a good callus formation uh, has occurred and it has united. So this is the post-operative clinical picture. This is another patient with the hypertrophic non-union, previously operated elsewhere. So here you can see the unstable bone ends. So this I opened it and did a squaring osteotomy and made the bone ends transverse. So this transverse bone ends give a good intrinsic stability, and then later just compressing the non-union site has led to healing of the non-union site. This is another patient where previously treated by nailing. You can see a necrotic butterfly fragment. It was lying free, so I had to open the fracture site. Patient was a Bharatanatyam dancer. She doesn't wanted a bone graft, or she doesn't wanted much scar. So, but she gave permission to apply a G bone graft. So I applied the G bone graft with mixed with iliac bone marrow, which I aspirated from the iliac bone. So as I said, axial loading and functional activity of limbs are very essential in order to stimulate the osteogenesis at the non-union side. So the patient was quite okay, and she had a good painless frame and walking properly without pain. So at the end of 9 months, it united, and this is the recent this X-rays immediately after removal of the frame, and this is after 3 years. She is quite comfortable and walking freely with no limb length discrepancy. This is another patient. It's a type of atrophic day one non-union. He had a open fracture, following which there was a bone loss, and surgeon he managed with just an external fixator. After 7-8 months, there was a atrophic non-union feature. So there was a flap also been done, cross-leg flap. So patient presented to me at this stage. So what I did was open the fracture site, uh, um, uh, make a transverse osteotomy, remove the excised the dead bone, and did a trifocal bone transport. That is one osteotomy proximally and the second osteotomy distally, and gradually started bone transport. So at the end of 10 months, so a good union was achieved. This is another patient with a oligotrophic non-union. See here, you can see the bone fragments again. It is unstable bone fragments. So what I did was just to interlock the fragments like this. I didn't open the fracture site, just interlock the fragments here, and then see within 3 months with just a compression, the non-union nicely got united. This is another patient with oligotrophic non-union, where just giving a compression has healed. So plating, before coming to me, he underwent multiple procedures, nailing, plating. So when he presented to me, there was breakage of the plate and non-union of the right lower end tibia. So I removed the plate and did it with a three-frame construction ring, just gave a compression at the non-union site. And here you can see so nicely painless. The frame is the baby is the child is walking, and this is at the end of 3 months. The fracture united. This is another patient. He is a police inspector. Underwent many surgeries prior to presenting to me. When we planned, there was two cora, but one cora was very near to the joint. So I just planned a normal deformity correction as a one plane. So this is how the clinical picture of the patient. So I pre-constructed the frame and applied it on the tibia as it is, and then gradually distracted. So at the end of 6 months, you can see the though the bone looks abnormal, deformed, but the mechanical axis is nicely well aligned, and this is how the patient is walking and is back to the duty now. This is another patient of hypertrophic non-union. It was like a pseudarthrosis. There was an abnormal mobility, and so this is how it was looking clinically. So in this patient, just I did apply compression, applied compression, and it healed nicely. So the patient was very comfortable on the frame. This is how it united, and now after 6 months, it has completely united. See how the functional activity is completely united, and he's a rank holder in his class. This is another patient where just giving a compression has healed. The surgeon has done only plating of the fibula. Tibia, he has just left it alone, thinking that it will heal. It looks like a little bit hypertrophic non-union, but I opened this fracture site in order to get the good internal stability by doing a squaring osteotomy, and hence the fragment ends, I made it transverse so that a good stable internal stability can be achieved. And just by giving compression, it healed. There are various other methods. When we open up the fracture site, this shingling can be done. It is nothing but elevating the sliver of bone and periosteum from the bone ends in order to increase the surface area as well as increase the blood circulation at the non-union site. So again, the Reni-Marti technique of decortication in the treatment of non-union. So here sometimes we may add a bone graft also in order to hasten the union. This is another patient where in case of it was a case of hypertrophic non-union where I had to do a distraction as well as compression. I didn't open the fracture site. Already it looked like the callus was forming. Only thing, it required a good stable frame. So I applied a three ring fixator, Ilizarov fixator, and then initially distracted it, and then later compressed it. Within 3 months, such a nice healing occurred at the fracture site, and you can see the patient is very comfortable walking in the frame. So this is another atrophic non-union of the forearm with the isolated radius non-union. The non-union was present for 10 years. So overall development of the left forearm was a little bit less. So I had little difficulty because the atrophic part was very thin. It was a pencil thin radius, and you can see the radius was so much migrated proximally. So I had to excise the dead bone, and I had difficulty in fixing the fragment with the shan spin and Ilizarov wires. So I did a distal corticotomy, a distal radius corticotomy, and started a bone transport. So prior to that, I did a distraction so that the radio-ulnar joint relation is well maintained. So it nearly took 1 year, 1 month, because it was a big transport. And ultimately, I could achieve a three cortex union. Though the X-ray looks bad, but clinically the patient was very happy, and the movements were pretty acceptable for the patient. So this is before so much deformity was there. Now the deformity is corrected, except some suppression of the supination. This is another femur non-union. Previously, surgeon has applied LRS and tried to do bone transport, but somehow the pins got infected. The patient discontinued the treatment. Patient never walked for 1.5 years, so he was not ready for Elizabeth, but somehow I convinced. And here you can see already there was little bit callus formation. It means that the fracture non-union site was trying to unite, but because of instability, it didn't unite. So I gave a good stable frame, internal stability as well as external stability, and it united. Patient refused lengthening, but he's quite happy with the shoe raise, and he's walking comfortably. He has stiff knee, but he is quite happy with the result. So take home message. So we have to identify the cause of non-union and type of non-union. Intrinsic stability of bone fragments and extrinsic stability of a good frame, painless frame, is very important. Hypertrophic non-unions heals well with distraction, compression, and or both. Oligotropic non-union heals by compression followed by distraction. Atrophic non-union needs freshening of the bone ends, bone transport, or bone grafting. Thank you.
Thank you, Dr. Satish, for the wonderful talk. And this is such a common topic. So I think everyone will be benefited from this talk. And let's go to our next speaker, Dr. Aradhana, on his talk on infected non-union. Dr.
Yes, sir.
Aradhana, please.
Yes, sir. Yes, sir. Sir, if you don't mind, I will play the video because here there is a lot of background noise.
Okay.
If it is okay with you.
Yeah, it's okay. It's okay. Yes.
Yeah, okay. Thank you, sir. Hello, good evening to one and all. Today the topic given to me is infected non-union. I have kept the topic as basic as possible and it is mostly case-based. Management part is already being covered in aseptic non-union. So I will focus upon the management of infection, when to do and what to do. If we see example of these two cases, on the left-hand side, we have a case of united fracture of distal femur with union, and on the right-hand side, we have a non-union of distal femur fracture. Why is it that these two cases
Prapurna, you
are
can see the video,
having
right?
different outcome? let us take another example. There is a case of proximal third tibia, infected non-union. It has united, even though the alignment looks invalgus, but still acceptable. And on the right hand side, if we see, there is non-union at the distal third of the tibia. Because in the tibia case, distal third tibia case, this patient was a case of chronic renal failure. And in this femur case, the patient had non-union and very, very poor bone quality, because already the patient was a case of chronic osteomyelitis with pathological fracture and managed by multiple surgeons, then referred to me. Now, if we see the infected non-union journey, it is a very long journey with lot of hurdles. Aseptic non-union is a kind of less difficult to manage as compared to infected non-union. If we see the hurdles, on the right hand side, we can see the athlete having a kind of expression which we usually all the surgeons managing infected non-union have during debridement, during follow-up, or during the course of complete treatment. And this is the way we fight with the infection in the theater. And at the end of the day, we look like this, like a unfeathered hen in case of managing infected non-union. But when we see aseptic non-union, it is not that difficult. Now, if we see what are the hurdles in managing infected non-union, the main hurdle being infection, especially when it becomes recalcitrant, or when it's polymicrobial, or when the infection is too much resistant to most of the antibiotics. And another important thing is when the infection is causing secondary damage, like giving poor bone stock, giving poor bone quality, having lot of gap because of secondary damage, having soft tissue fibrosis or contracture, giving secondary deformities, or giving very, very bad soft tissue quality. The consequences we all know, it is really bad, especially when the patient runs around for 2 to 3 years with pouring pus in the leg or extremity. So what I feel, or what all the surgeons who handle infected non-union feel, is early, correct, definitive intervention is the key for success. And it is very, very important. If a person doesn't know how to manage infected non-union, the person has to refer it to the surgeon who is usually managing it, because it is not that easy. We have to have a team when we are managing infected non-union. It can be a plastic surgeon, it can be physician, it is anesthesia as well, experienced nursing officers who can help us in managing these cases, a microbiologist, a pathologist, have good rapport with them so that you can go personally discuss with them. If you have microvascular surgeon, it is very, very good. In clinical evaluation, especially in cases of infected non-union, what is important is what treatment was provided prior to coming to us. That is type of treatment, number of the surgeries, and presence and treatment of previous infection which was there or not. Important thing which we are supposed to remember is if the patient is diabetic, if the patient has any kind of metabolic sin in managing the case. Let us take an example again. This patient was referred to me in this way after putting an external fixator, and he had in fact pouring pus from the site of non-union. He was diabetic. In fact, we had a lot of difficulty in controlling the sugars of the patient, and patient was put on insulin prior to surgery. So we put him on fixator, sent him home. Again, the patient comes back with multiple abscesses everywhere in the thigh because he was shifted from insulin to oral hypoglycemics where the sugars were not in control. So these are the kind of cases which are very difficult to manage, especially when the patients do not have access to proper care or a proper medical care. Another example of chronic alcoholic, especially he landed up in depression and started taking alcohol, and he was not having that great family support when I discharged him, and he started consuming alcohol, had very bad abscess, and this is how the skin looked after he went home, and again he came back. Another case of chronic stubborn smoker, which I can say patient still is with me, and patients, none of the ulcers are healing well. He is not quitting the smoking, and he still had persistent non-union, and I have done a kind of vascularized and muscularized fibular graft in this patient. Uh, uh, I hope it unites now. Now, occupation becomes important because we have to give him the occupation which he was previously in. And planning of discharge really depends on successful aftercare and outcome, because patient's living situation, condition, family support, friends, everything matters in the outcome of these patients. We all know what to see in case of non-union. Important thing in infected non-union is check for the contracture of adjacent joints, and please get a Doppler or angiography, especially when the patient, you are the fourth person or fifth person who is treating these kind of cases, so that you can document any untoward consequences which have happened prior to you touching the patient. Radiological evaluation, all of us do that in these kind of cases. Take complete length x-rays. If possible, get a scanogram done. Do not miss these kind of lysis or cavities. I will give you the case example in later slides, why these things become important. Check for any sequestra, any bone loss, and ends of the bone as well. And another important is these are kind of moth-eaten appearance at the edges, which shows the invasion of the granulation tissue here, which will give a favorable idea of how much to resect. Radiological evaluation, CT scan are done, especially in subtle non-union where multiple sequestra are there, or in case of chronic osteomyelitis with pathological fracture and then going for non-union, where we want to see how much of the debridement has to be done, even proximally or distally in these kind of infected bones. PET CT, if it is available, well and good, because it gives us a fairly good idea regarding the infection. Evaluation, this is important slide I felt, because I took this picture from Campbell, where they say if there is a subtle infection where you are very thinking whether it's going in infected or aseptic, get the ESR, CRP and WBC count done. There were articles which say that if the three are high, then the probability of having an infection is almost 100%. So get the investigation done and get LFT, albumin levels done to know fairly good idea regarding that. So I found this classification and scoring system very, very useful. Initially, it was published in 2008, then again modified by our own professor, Dr. Milind Madhav Chaudhary, for infected non-union of tibia. Sir has given scoring system, that is non-union severity score. I will not go in the detail of non-union severity score because I want to focus more on infection severity score and the importance of it, because every component of it is very, very important. You have to document everything in while handling a case of infected non-union. So this is mainly done for tibia, but there is no harm in following it for the femur as well, because it is a kind of documentation. If you see, especially when the implant score is being given, nailing is and multiple surgeries are being given higher score, which indicates poor prognosis if there are multiple surgeries done for the case. So this is the checklist which we follow usually. Be ready to contemplate bone loss, especially in cases of femur or humerus, where you are supposed to keep blood ready during the procedure. So document, assess, and reassess. Documentation and assessment still goes till the debridement is over, and reassessment is done after the check X-ray is done. So principles of treatment are: important is control of infection, then stabilization, management of soft tissue defect if present, management of bone defect, achieving union, addressing lengthening. All these three are similar in line with aseptic non-union, and physiotherapy, of course. Control of infection is very important because there is no replacement for debridement. No tons of antibiotic is going to help in control of infection like a debridement does. So I call it as no mercy debridement. Resection of normal bone is always better than leaving infected bone there. Large sinus tracts has to be curated out. Take out the underlying granulation tissue, take out all the loose implants, and medullary canal has to be reamed in case it was nailed previously. Now, do not forget to take deep cultures and biopsy. All the cases should get cultures and biopsy done, because I will give you an example of the same case which I had. This patient was destitute, homeless, already treated with LRS, and it failed. He had persistent discharging sinus. The failure was probably due to, it came out to be tubercular non-union. That is why the patient had never union in this case. And I planned for distal corticotomy initially, then lengthened, and I felt the regenerate may not be very good in this case. So I planned proximal also, which I should not have done probably. After 1 year of ATT, I planned a proximal corticotomy, and the regenerate was really poor, and I had to graft it. In spite of grafting and waiting for 6 months, this is the outcome of the patient. And I had to remove the fixator because patient started becoming very, very uncooperative. He stays in fact, in a bus stand. He doesn't have house. And he was requesting a lot for removal of the implant. In fact, the pins had become very loose. So I removed it. Now I am planning to keep him in cast for 3 months. So this is the importance of biopsy and culture. That is why I gave the case example. VAC, of course, helps, especially in cases where copious discharge is there, and in spite of debridement, you are still having discharge, and you are supposed to remove all the sutures, and what next? So in these cases, you can plan for VAC. It helps in giving you very good granulation tissue. One thing helps in approximation as well. This is important slide. It tells you the importance of local antibiotic delivery, especially if the whole medullary canal is involved. Then consider for having a antibiotic coated rush pin or a TENS nail and put it in the medullary canal so that it will take care of the local bacteria there or a remnant bacteria there. If it is a local kind of infection, then you can go with a block or beads or absorbable calcium sulfate. We do not have access to calcium sulfate in our institute, so most often we go with polymethyl methacrylate. When to remove? 6 weeks are more than enough for the removal of the spacer. But in cases, especially distal tibia, where plating was done or where the skin is very, very thin, this is one of my example of case, one of where the skin was very thin. I gave few more time for the skin to mature so that I can take a second incision. Staged or a kind of single stage surgery is another question which most often is asked. Most of the non-union, especially with intramedullary nail, prefer a staged procedure in these kind of cases. Let us take an example again. This patient, in fact, after nailing, patient had pouring pus everywhere through the entry point, through the distal locking site, through the fracture site. This was a condition when he came, diabetic with streptococcal infection and septicemia. In fact, we had to remove, debride and re-debride in these kind of cases. So I can't expect a single stage in him. We had to put wax for him. Then we got a very good granulation tissue. So again, another example where I was given this case of gap non-union of tibia, where this case was given to me, sorry for the time. This case, then I put a frame and referred back to plastic surgery for the management. But the patient over enthusiastic, he went to some other surgeon where he underwent corticotomy without having any kind of soft tissue coverage, and patient landed up in infection and bone exposure, and he landed up with amputation. Now, this is the importance of local wound management after soft tissue defect. If it is very, very large, then plan with plastic surgeon. If it is small, then do a local closure methods. It can be shoelace method or just approximation, or you can use your own fixator to close it. Or this was one of the rare case which I did because I did it in some other hospital where plastic surgeon access is not that great, where I did corticotomy at 2 levels and rotated the second and third ring in opposite direction so that the convex wound becomes a kind of a shape and I can get some approximation. So you can go with a flap like this. For a proximal tibia, a flap was done in one of my case, or a skin graft, of course. So fixation is similar to aseptic non-union. You can go with internal fixation, especially where infection severity score is very less, like maybe 25 to 30 out of 100, or best will be an external fixator, whichever person is comfortable with. How to dock? Of course, matching ends are better, and grafting. So if you are planning to open the site, non-union site where flap was done, you have to plan your incision with plastic surgeon. And these are important when there is high non-union severity score with long bone transport. Fibula ipsilateral can be done gradual. Sometimes we do acute, or it can be done contralateral where you need vascular surgery intervention. Mascalade also can be done in small gap non-union. So this is one of the example of my mascalade technique where it took up all the graft, double strut fibular graft I have put. This is the acute fibular transport which I have done. This is 4.5 years follow-up. This case was a orphan child which did not have any kind of social support, and I didn't have a very good access for follow-up. So I had to do acute in vitro fibular transport in this case. These are very rare indications for long gap non-union where you can go with acute transport. Always gradual is preferred. So when to do mascalade? Mascalade success, this is one of the successful result of a mascalade technique in this lady. This is unsuccessful. Why it fails? Recently, we have published an article of distal femur fracture managed with mascalade method, where the conclusion given was that technique gives promising result in patients with low infection severity score, but the cutoff we still don't know because this was a case series. So in the case series, the cases with ISS less than 70 had better results. If thinking of tibia, then it gives, of course, it has to give very good result when there is a lot of soft tissue around. So otherwise, distal tibia or shaft may not give promising results where transport can take over these kind of cases. Gap management is similar to any kind of aseptic non-union, but doing a when to do corticotomy has to be decided. It can be a unifocal, bifocal, or trifocal transport. We all know docking site problems. Manage it accordingly, like any aseptic non-union. This is very promising videos what you get when the patient sends to you, and we feel really happy. At the conclusion, the time to union depends on multiple factors. So most of them are patient-based factors. What is in our hand, a surgeon's hand, is debridement and what tools we are using to treat the patient. So use a proper tool and do very, very good debridement. Infection and non-union severity score does have effect on the functional and radiological outcome, and patient like IV drug abusers, alcoholics, smokers, ASA grade 3 or 4, they are not very great patients to have during treatment of infected non-union. These are my references. And last but not the least, we all know it's a long journey. We might have this kind of effect in most of the days while treating the patient, but the end result of the journey should be happy patient and happy surgeon, and we forget the pain when the patient comes with priceless smile. Thank you so much.
Thank you, Dr. Aradhana, for your excellent talk on infected non-union. I think this is one of the most important topics of Ilizarov. And Ilizarov is, I think, the gold standard and one of the only options in cases of infected non-union. So today I think all the viewers, they heard the very important talks on non-union, the non-infected and the infected. Now we'll be proceeding for the case presentations. So, Dr. Aradhana, will you please invite our presenters for their cases?
Yes, sir. Yes, sir. Maruti, sir, can you share your screen, please?
In the meantime, if anybody has any questions for the wonderful cases. Harshad, sir, any comments, sir? Please unmute, sir. Please unmute.
Unmute, sir.
Yeah. Yeah, you were asking something, Shamsul?
Any comments for the cases of Dr. Aradhana, Dr. Nesari, sir? Any comments?
Yeah, excellent cases. I could see 3/4 of them, not all of them, because I was on my way back. And now, well, she has covered up most of the things. The gap non-unions, small gap non-unions, large gap non-unions, lower limb, upper limb. You have different situations in different things. So masculine technique is a very promising one, what she has told. My congratulations for a very good presentation. In a short time, she has presented so much, so many cases, so many examples. I think we have hundreds of them. Each one of them behave differently. When you treat in one way, the results turn out to be something else, and then we try to keep on operating again and again to get better and better results. I think one thing most important is the stability. When it comes to tibia, more of transosseous wires I would prefer compared to half pins. I have found half pins delay union, delay regenerate formation a lot. Otherwise, whatever she has presented, coverage of the skin and everything else is excellent. Good work. Congratulations.
Thank you, sir.
Yeah.
Yes, Aradhana has shown very, very, very nice cases, and even Satish, sir. So we have to differentiate when there is a aseptic and aseptic. Protocols are a little different for both the cases. You have to get learned and do cases meticulously. Protocols are very, very important. So are we ready for the next presentation, Aradhana?
Sir, then we will go to Dr. Varush. Varush, if you can share your screen till Maruti sir's screen is taking some time, I think. You can share your screen. Yeah.
Good evening, everyone. Happy Diwali. I'm Dr. Varush Rao, consultant orthopedic surgeon from Mysore. I have done my fellowship in deformity correction, limb reconstruction, and Ilizarov under Dr. Mangal Priyar sir from Center for Limb Learning and Limb Reconstruction. And I will be presenting a case that was operated during my tenure of fellowship. This is a case of pediatric post-traumatic deformity. It is slightly different from the topics that are discussed previously that were non-unions. So a 13-year-old male presented to us around August 2022. Came with a history of RTA in November 2019. He had a history of fracture and cast was applied for 6 weeks. Unfortunately, he did not bring any X-rays or any sort of documents with him about the previous injury. After the cast removal, he had the deformity, which was insidious in onset and gradually progressive. He did not complain of any pain, no restriction of activities of daily living. He was able to run, walk, play without any discomfort. So his only complaint was the deformity. On examination of the right knee, I will be showing you the clinical pictures in the next slide. He had recurvatum deformity. ROM was minus 20 degrees to 130 degrees. Varus and valgus stress test were negative. Anterior drawer test was negative, and he had an unaided bipedal biphasic gait. So coming to the clinical pictures, you can see the red arrow marks. You can see slight valgus deformity on the right side, and there's recurvatum deformity if you see on the lateral views. And from posteriorly also you can see slight valgus deformity. The knee ROM is minus 22, around 120, 130 degrees of flexion. And if you see his gait, it almost looks normal. There can be any abnormality seen on the gait. You can see his gait from the side as well. He's walking normally, except for the slight deformity that you can see. So coming to the pre-op X-rays, we get his X-ray done. We'll see that there's some slight deformity, but apex of the
good evening.
valgus deformity is not clearly visible. On the lateral X-ray, we can see that the proximal tibia is in line with the distal femur, but the apex of the deformity looks to be here, and there is a clearly visible recurvatum deformity. So we get full-length AP views, but there is slight difference between these two X-rays here. The X-ray on the left is with his feet at the in line with the opposite side, with a block making the pelvis square. Here you can clearly see that the knee joint is not clearly visible as the opposite side. This is the on the right side. You can see the X-ray is taken with the foot slightly forward so that this knee is extended fully. Now you can see the knee joint is clearly visible, but there's a difference in the degree of deformity you can see on the knee with flexion and knee with full extension. So we do the pre-op planning. We get the spot films as well as the full-length X-ray. On the spot film, we take the MPTA as 87 degrees and get the mid-diaphyseal line. We can see the AP cora here with 9 degrees of deformity, valgus deformity. On the lateral view, we get the PPTA to 80 degrees and a mid-diaphyseal line. And we see the lateral cora here with 40 degrees of deformity. If you draw the transverse bisector line, you can see that line appears to be slightly above the apex of the deformity, suggesting that it could be an angulation translation kind of deformity. But on the full length X-ray, if you see, the HK is 163 degrees, meaning there's around 17 degrees of deformity, and the LDFA is 85. And if you draw the transverse bisect, this mid-diaphyseal line and the MPTA, the deformity appears to be at the same level, but the degree of deformity is 18 degrees. There's gross variation in the deformity seen in this spot film and the full length standing X-ray. So we proceed with the surgery. We decide to only correct the recurvatum for now. We did the oblique fibular osteotomy, Ilizarov fixator application, and percutaneous tibial osteotomy. The first wire, the reference wire, is inserted lateral to medial, parallel to the joint and parallel to the ground. The pre-constructed frame is placed and fixed with wire fixation bolts, and this is the lateral view. You can see there is slight angle between the tibial slope and the first ring, but the hinges are overlapping and they are in the plane of the deformity, sagittal deformity. The ankle ring, the third ring, is placed parallel to the ankle joint, 2 centimeter above the ankle joint. So these are the lateral view of distal ankle. So once the frame is fixed, we put in further wires, the transfibular wire proximally in the first ring, and anterolateral to posterior medial wire in the third ring, and we add more Shan's pins. Then we do a percutaneous tibial osteotomy, and we complete the osteotomy with this osteotome. We turn the osteotome so that the fragments are separated clearly and the osteotomy is complete. In these two Siam images, you can clearly see that these are the hinges and the nuts are removed here so that the osteotomy is completed without any hindrance. Once the osteotomy is complete, we put back the nylock nuts here and fix the motor so that the cortices come back to its original place. So this is the immediate post-op X-ray. You can see this is our osteotomy site and this is our hinge. This is the first ring with 2 wires, 2 screws, second ring with 1 Shan screw, and the third ring is not seen, but it has 2 wires and 1 screw. So in this, you can see that the red arrow shows the level of osteotomy and yellow arrow shows the level of the hinge. So the osteotomy is at a different level than the hinge. That means we are following rule number 2. That means there will be angulation and translation at the end of correction of this fixator. This is the immediate post-op clinical image. This is the osteotomy, percutaneous tibial osteotomy, and this is for oblique fibular osteotomy. These are our hinges and these are motor. So the issue is that when we have done this kind of osteotomy at a different level, if we start dissection at the motor, sometimes there will be less space for the distal fragment to move posteriorly, and there will be hindrance to the correction of angulation. So what we do is we distract both the hinges as well as our motor for 7 days so that there's an equal gap at this osteotomy site. There is no correction of angulation or translation, but it's just a distraction. So the left images you can see there's no gap between the flag and the nut. And after distracting for 7 days, here we can see there's a gap between the nut and the flags, meaning it is equally distracted at the hinges and the motor. After 7 days of distraction at 1 mm per day, then we start distraction at the motor only. We release the nylock nuts and we start the distraction at 2222, meaning 2 mm of distraction on the motor for 20 days. This is the image after 20 days. You can see the rings are still not yet parallel. So we continue the distraction, and at the end of 1.5 months, you can see these rings are almost parallel and we've reached the end of this rod. But when we take the spot films and full length X-ray, we draw this MPTA line and mid diaphyseal line, we get a core of 9.4 degrees on the AP view. And when you draw the line on the anterior femur and shaft of tibia, they are still not in line and there's still 7 degrees of angulation translation left. And when you get the full length X-ray done, compared to what there was in the pre-op X-ray, it was 163 degrees, the HKA, before correction of recurvatum deformity. After correction of recurvatum only, we get a HKA of 188.4. The LDFA is same, and now the MPTA, when we measure it, it's around 95 degrees. So we then choose to put the depth fix, that is the 6-axis fixator. With the hinges and motor in place, we put in 3 Y connectors to the proximal and the second ring, and then we fix with this depth fix. These are 6 struts here connecting the first ring and the second ring on the AP view and lateral view. So after taking X-rays with depth fix in place, we have to upload it on the software, and we have to tell the software the lengths of each struts. And then we have to mark the MPTA to around 90 degrees. This is around 90 degrees. the green line. And this green line on the lateral view is the PPTA that is marked at 80 degrees. So we can see two boxes here, the yellow one and the blue one. The yellow one represents the current position of the bone, and the yellow line represents the current distal axis on both AP and lateral view. But the blue box is what we intend the future axis to be. We want the future bone to come at the place where this blue box is, and we want the blue line to be in line with the green line so that our axis come to the normal alignment. So once we tell where we want the axis, the computer program tells us the amount of correction that is to be done, in the sense that 9 degrees of valgus has to be corrected with 6 mm of lateral translation, and on lateral view we need 6 degrees of recurvatum correction and 6 mm of anterior translation to be corrected, and we compress the site. So this the clinical picture after application of the def fix. So these are the 6 struts, 1, 2, 3, fourth one is not seen here, fifth and sixth. But on the lateral view, you can see 1, 2, 3, fourth. The fifth is not seen, and again the sixth. Basically, the theory is that when you lengthen this strut and when you shorten this struts, these two struts, it will correct the valgus deformity. And on the lateral view, if you lengthen this strut and if you shorten these struts, it will correct the recurvatum deformity. But it gives you the exact correction. So it gives you a schedule where you have to turn these knobs on these struts every day, 4 times daily, so that the correction is done. So post correction with the def fix, you can draw the lines and you will get that the MPTA is 89 degrees, which is normal, and the PPTA is 80 degrees, which is again normal, and HK has come to 182.3 degrees. It is in slight valgus because we've not corrected the valgus in the femur. I mean, not the valgus, but the LDFA is 85 degrees. So there will be slight constitutional valgus. So this clinical image after correction, AP and laterally, and you can see that patient is walking full weight bearing with the walker with def fix in situ. So once the correction is complete, we change the def fix to straight rods, and you can see that there is a bone gap posteriorly, but the regenerate is forming now. After changing to straight rods, we can see the limb appears to be straight and recurvatum has been corrected. 2.5 months post-op, bone formation increase, regenerate improves. He is walking full weight bearing with walker. 3 months post-op, further improvement. The posterior gap has further improved. 3.5 months, we can see it's almost fully filled. Now he starts walking with walker, but he uses it only for support. He leaves the walker. You can see that he leaves the walker while walking, and he puts full weight on the operated limb. This 4.5 months post-op, the bone has almost healed. Once he's walking well with the walker, we shift him to a walking stick, and he's walking well with the stick. 5 months, again, he's walking much faster. Healing has improved. Regenerate is better. 6 months post-op, it's almost healed. It's time for removal. So he's walking with the stick. We ask him to put his hand in the pocket so that the abductor lurch decreases. So at 6.5 months, he comes to us and we decide for stress test. In stress test, what we usually do is we loosen these nuts between the first ring and the second ring, on the rods between the first ring and the second ring, and we make him walk. Before loosening, we take the length between the first ring and the second ring on all the rods, and it is recorded. If there is any discrepancy more than 3 mm between these rings, it suggests that there is still healing. Healing has not fully happened, and we need to wait. So the other thing is on the X-ray, we see that the bones have completely healed. There is no gap between the two fragments. But the third thing is that we also see how the gait of the patient is. We can see that he has a slightly unstable gait. He has this abductor lurch and he's limping with the gait. So we decide to keep the fixator for another 2 weeks. We put back the rods and keep it for another 2 weeks. And then we compare with the old video. We see that his gait has improved. His abductor lurch has decreased, not fully gone, but it's less than what it was before. Then we decide to remove the frame. So this X-ray is immediately after removal of the frame. The bones have healed, and on drawing the lines, we get that MPTA is 89 and PPTA is 80 degrees, which is almost normal. So this is 3 months post removal of the frame. He's walking normally, can't make out which limb has been operated. No issues whatsoever. So our learning point from this case was that positioning of preoperative X-ray are important to determine the plane and amount of deformity. Basically, the X-ray with knee inflection and knee extension showed different degrees of valgus, and the X-ray with spot film and full length with knee in extension showed different degree of valgus. So that is why we did not choose to do an oblique plane correction in this case. So correction of recurvatum only was done, and it revealed the residual valgus, which was corrected with deft fix. The use of deft fix for finer corrections in all planes is it's a boon. And unstable gait on stress test indicates that the patient is not yet ready for removal, and you have to give him and then remove it at a later date. Thank you all.
Yeah. Thank you, Varush. It was a very good case, and every minute detail of how to plan for a deformity case, what all the problems you face, everything has been explained in detail. It was a very good case, in fact.
Thank you, ma'am.
Yeah. Shah, sir, if we can go to the next case. Shamsul,
Any
sir?
question? Any questions? Because it's a very interesting case.
Yeah, it was very interesting case. Even I feel if there are any questions we can take.
If Harshad has any question, then I'll ask something. Harshad sir, any tips, sir?
Well, beautifully presented and very well done. As usual, Mangal Pari the top of the world with all these kind of things. Very well explained also with excellent results. Only one question is, could you have used desk fix from the beginning?
Yes, sir. We could have
My
used
question,
yes,
could
sir.
you have used the desk fix from the beginning for the whole procedure in one step?
Definitely, sir. It could have been used. But the thing is, in deft fix, the patient has to turn 6 steps 4 times daily. So it could become tedious for the patient. Otherwise, it can always be used for such cases.
You got a very quick and very good result. Congratulations.
Thank you, sir.
Well presented.
Shamsul, sir, I think you also had one question.
Yes, Dr. Varush. The same thing. I wanted to ask that if you do a very good pre-op planning, like in bone injury or something, so we can avoid 2 surgeries, like one surgery and one Ilizarov and Vestic. So very good pre-op planning is very important, calculating everything. So my one question with Dr. Varush is, did you calculate for the soft tissue calculation, that is the anterior cortical line? Because in such deformities, we have bony deformity as well as the soft tissue deformity. We have to calculate the ACA. So that we have to correct the bony as well as the soft tissue or not. Did you do that or not?
You mean the JLCS, sir? In
The ACA, this anterior cortical line, to exclude any soft tissue involvement for the such deformities.
No, sir. In this, that planning was not done.
Right. So if you go through the Hazenbach's book or Palace book, you have to also calculate for the parietal view, we have to calculate the ACA, that is the anterior cortical line, the line that crosses from the anterior cortex of the femur and the tibia. And normally this should go in a straight line, and then we calculate if there is a bony deformity plus soft tissue deformity. There is a formula for that in the book. So for the youngsters, we have to calculate before doing the surgery. You do a bonnet correction, and then finally you get there is a soft tissue laxity also. Then there are deformity persists. So you have to meticulously calculate the SCA also to exclude any soft tissue component or the bony component. So you have to do a body correction or soft tissue or either or both.
Okay, we'll keep that in mind. Thank you.
I think Dr. Aradhana, that is very important actually. My second question is because that was a ring around the knee. So did you had any stiffness around the knee or not post correction?
No, sir, there was no stiffness around.
So range of motion was good.
Yeah,
So my message to the youngsters that as Harshad sir told very well, either we can do a DefFix or an Ilizarov, plan very well, plan on Bone Ninja or any other app or do a paper planning so that you do the exact calculation to get an exact post-op results at the end on, right? And very, very wonderful case, Dr. Varush. Congratulations.
thank you, sir.
If there are no questions, then we can move to the next speaker. Thank you, Varush, for the wonderful case. I think there is some problem with Maruti sir's sharing of the screen. So I will be moving the slide for sir. I will share the screen for him. I hope the screen is visible now.
Yeah, it's visible, madam. Thank you, madam. Thank you, Aradhana, madam.
Okay.
I want to wish happy Diwali for everyone, and I want to thank all ASAMI group because of the basic deformity course which was held in Bangalore and ASAMI Con Goa. I learned a lot from these two events, and we started the Ilizarov technique for difficult cases in our Chamarajanagar Institute of Medical Sciences, which is the bottom of the Karnataka, bottom district of Karnataka. And the first case we did, where we did Ilizarov, was for this case, a case of a stress fracture of right tibia. The patient was suffering from cellulitis in the same leg and managed with Ilizarov. And the other two cases were which I am not presenting, previous slide, which I am not presenting. There is a forearm ulna and radius non-union, and the third case is the tibia non-union. So their treatment is still in progress. The first case which we started Ilizarov technique in our institute, which I am presenting today. Thank you for Shah sir. He was my teacher in undergraduation in MS Rama Medical College, and I want to thank Aradhana madam for giving this opportunity. Next slide, madam. The stress fracture refers to fractures occurring in the bone due to mismatch of bone strength and chronic mechanical stress placed upon the bone. Cellulitis and acute diffuse spreading infection of the skin involving the deeper layers of the skin and subcutaneous tissue. But if severe or if left untreated, it can spread into lymph nodes and bloodstream. Introduction. Next slide, madam.
Yes.
Normal bone is subjected to repeated episodes of stress less severe than that necessary to produce an acute fracture. Stress fracture is an overuse injury caused by muscle forces together with bending and impact force acting on the bone, which has not adapted to the loading. Next. The risk factors are extensive training regimens, usually in a military recruitment and training surface. There is an irregular surface, and intrinsic factors like the malalignment, nutrition, overweight, smoking, and the non-steroidal anti-inflammatory drugs. Next slide. If you see the pathogenesis of, next slide, ma'am. Hello, Aradhana madam. Hello.
Sir, give me 30 seconds. I will rejoin. There is some problem with the. I'm extremely sorry for this. I'm joining in a second. Yeah.
Recording in progress.
Hello.
Hello. Hello.
Yes.
Yeah, I think now my screen is visible.
Yes,
Yes.
well, madam. Yeah, next slide. Yeah. If you see the pathogenesis, there is a rapid increase in frequency, duration, or intensity of an athletic activity without adequate period of rest, which will lead to disruption of the normal bone remodeling, which will lead to the osteoclast-mediated bone resorption in the Haversian canals and the interstitial lamellae. A small crack appears at the cement lines of Haversian system, which propagate into microfractures. The new bone formation occurs as a result of increased periosteal osteoblastic activity. Next slide. Coming to our case report, a 72 years old housewife presented to our orthopedic OPD in Chamarajanagar Institute of Medical Sciences with a 1 month history of pain, swelling in the leg for 1 month duration, and this with a disrupted daily routine activities. She was diagnosed with stress fracture with cellulitis and HbSAg positive in our blood investigations. Next slide. The following symptoms were seen in this patient when patient encountered in a OPD: the pain in the right leg, swelling in the right leg, reddish discoloration of the limb, and unable to walk and disrupted daily routine activities. Next slide. Signs were swelling, reddish discoloration, varus knee, and tenderness of the joint line and right proximal tibia. This is actually post-op X-ray film which we can see here. And the laboratory, next slide. Laboratory investigation showed there was a increased neutrophilic leukocytosis and increased CRP, increased ESR, and LFT, RFT, and serum electrolytes were normal. And the patient was, her HbSAg status was positive. Next slide. Course in the hospital, patient was admitted and routine investigations were done. She was treated for cellulitis with antibiotics and the magnesium sulfate dressing for 7 days. And the long leg POP slab was applied for the management of stress fracture, but on 1 month of follow-up, there was no signs of union. The patient was planned for minimally invasive surgical technique for stress fracture. This Ilizarov technique was chosen and used for the fixation. And the sequential X-rays was taken at 2 to 4 weeks of interval. Next slide. The preoperative planning and management, management of cellulitis 1 was done, and preoperative measurements of the limb and their Ilizarov ring preparation to avoid prolonged surgical time and the biohazard exposure. I've taken this proximal 5/8 ring, and other 3 rings were complete rings of 180 millimeters, with 2 guide pens for each ring was used. Next. Intraoperatively, prepared Ilizarov ring was used with guide pins with correction of the varus knee by medial translation of the distal tibial fragment at the stress fracture site to really get relief from the osteoarthritis in the knee joint. Postoperatively started compression from postoperative day 7, 1 millimeter per day. Compression till docking is achieved. That is only 5 millimeters of docking was achieved here, and correction of the varus also done. With that, cellulitis was also subsided. Course of postoperative rehabilitation, serial X-rays were taken after compression and achieving docking at fracture site. Regular physiotherapy of the limb was done. The rings were removed after 8 weeks and immobilized with the POP slab for another 4 weeks. Started walking with support after removal of slab. Post-op at 1.5 months and a 6 months follow-up. Next slide. This is the 6 months follow-up of 6 months follow-up. There we can see there is a complete fracture, stress fracture is completely united, and there is varus correction was also achieved at this by Ilizarov technique at the stress fracture site itself. Next slide. This is the post-op follow-up X-ray at post-op picture after 6 months. Recently, I think over 2 weeks back, we have taken this picture. The patient is comfortably standing and walking without any pain. Patient was able to walk pain-free and devoid of osteoarthritis, whereas the symptoms also, and able to do her routine daily activities. And then next slide. Conclusion. As stress fractures are common in anterior tibia and most of them can be managed by rest and immobilization for adequate time. But in case of delayed union or non-union, with exceptional conditions like cellulitis or any other circumstances, opting minimally invasive techniques like external fixation or Ilizarov would be perfect option for the management of stress process with great outcomes. These are the references for our case report. Next slide. Next slide. Thank you, madam. It's a very simple case we have taken as an initiative to start Ilizarov in our institute. We achieved fracture union, and patients is also get relief from the osteoarthritis of the knee symptoms. Thanks for these Ilizarov techniques, and thanks for ASAMI Goa and deformity correction course which was held in Bangalore, conducted under the leadership of Dr. Aradhana madam and Dr. Harshad. Thank you all.
It was a wonderful case which you have presented, and it is not easy sometimes to treat these kind of cases. It might trouble you a lot while treating. Shah sir, any comment on the case?
Well, I'm happy more and more people are picking up Ilizarov and doing a lot of things. I'm yet to see such a case. Of course, varus knee joint. When proximal tibia was not good, I have done a little bit distally, use rule 2. Anyway, this is a good case. And you have done a good job. Well done. Maruti, well done.
Thank you, Master. Thanks for your blessings, sir. Thank you.
You were in Ramaya, no?
Yes, sir. Undergraduation from Ramaya, sir.
Okay, great. Good.
Thank you, Master. Thank you, Master.
Yeah.
Any other case from any Shamsul sir?
Yeah, thanks, Aradhana. Thanks all of you for wonderful cases, wonderful learning, and let the ride keep going. Thanks, Asad sir, for coming, for blessing us, everybody. And I just congratulate everybody from Karnataka side, all the youngsters. Special thanks to Aradhana for organizing this program. And next we have UP and Uttarakhand next month. It will be by Dr. Rajat sir. We'll be having a video interactive demonstration of the TBA frame. In the meantime, we may have a West Bengal budding laser surgeons on 15 November. And I welcome you all for ASAMI Con 2025 February month. So with this, there is no question. We can say goodbye.
One more.
Yes, please, sir.
I from ASAMI, from your side. Welcome for IOACon. Come on, Aradhana.
Yes.
Yours is before that, no?
Of course, yes.
Then Aradhana is the boss for IOACon.
We have to welcome. You
IOACon,
are the boss.
Ilizarov
I am just a puppet in nothing. Yes, sir. We have very wonderful session for ASAMI and we have very good workshops. So if someone has not registered for IOCon, we all welcome you to IOCon, which is in Bangalore this year, 10th to 7th of December.
So see you all at Bangalore.
Okay, we'll all meet at Bangalore and then at Chandigarh.
Yes, then Chandigarh. सर एक बार बता दो कि अर्ली बर्ड स्टॉप हो गया या अभी भी है या अर्ली बर्ड ऑफ ASAMI Con? I think
early bird. I think the date is still on. Early bird we can do.
Okay.
Still on. So
okay.
Yeah. So we request all you to register in time. Save some money also.
Okay, good.
I know. Yes, sir.
Very nice to see you all.
Yeah.
Excellent.
Thank you so
Very
much, Shah,
today,
sir. Thank you so much.
Thank you. Because of Aradhana.
Yeah.
I
Sir,
came back from there and
Yeah.
No.
Yes, sir. Thank you, sir.
Your
Sunday you
lecture
are
was also
coming.
very good.
Thank you very
Excellent.
much,
Yeah.
Harshad sir.
Satish Mysore, as
Thank you very
usual,
much.
is also very good. He has become big punters, you and Aradhana. Very
Yes,
happy for Karnataka
sir.
and for Assam.
All your blessings, sir. All your blessings.
Great. Good.
All your blessings,
Shamsul to
sir.
pura
Yeah.
upar chal gaya hai. I think he is on the moon. Huh?
All your blessings, sir.
Great, yeah. Great,
Sir is
great.
back to work. Yeah,
Mm.
yeah. Thank you. Thank you so much. Thank you all for joining.
Today's session.
See you all next month.
Thank you very much, Shamsul sir. Thank you, Aradhana ma'am. Thank you, Harshad sir.
Thank you. Your case was really wonderful. Very happy with
Wonderful
it.
case.
If
Wonderful
everybody
case.
understands deformity correction
Yes.
with that much clarity, everything becomes more easy. Yeah.
Yes, of
Very
course.
methodical,
Yeah.
very step by step, very good.
Thank you, sir.
Very good. Yeah. We
Thank you
had
for the
variety of
opportunity.
cases. Yeah.
That's okay.
Thank you.
Okay.
So, with this, can we start? Mahasi, can we stop?
Okay. Recording is stopped, sir.
Now
Yeah.
recording is stopped.